Good day, everyone. I'm Adrian Tablante, and I'm here to present my study entitled Percutaneous Implantless Basal Closing Tracheostomy for Hallux valgus, Surgical Technique and Preliminary Results in 114 Patients. Here's the outline of my presentation. I have nothing to disclose. Hallux valgus is defined as subluxation of the first metatarsophalangeal joint with progressive abduction, rotation, and lateral deviation of the great toe. Numerous surgical techniques have been described to treat these deformities. However, there is currently no gold standard for treatment as of yet. Hallux valgus has traditionally been treated with open surgery. However, these open approaches have led to soft tissue scarring, joint stiffness, and cosmetically unappealing scars. Moreover, extensive bony exposure increases the risk of infection, osteonecrosis, and pain from hardware material. This brings us to the conception of percutaneous forefoot surgery, which has the same operative principles as open surgery with a significantly smaller incision. This technique offers the advantages of less operative trauma, preservation of soft tissue blood supply, reduced surgical and rehabilitation times, and a happier patient. With this, we would like to present our technique called percutaneous implantless basal closing tracheostomy, which bypasses the need for any internal fixation and instead relies on surgical technique as well as a post-operative bandaging technique, which provides added stability to the correction. The objectives of our study are to present the surgical and post-operative bandaging technique, to determine if our technique could achieve a satisfactory degree of deformity correction for mild to severe deformities, and to determine complications, clinical outcome, and patient satisfaction of this procedure. A retrospective review was conducted on this technique performed by two senior authors for mild to severe hallux valgus deformities from 2016 to 2018. All patients had symptomatic hallux valgus on one or both feet who had failed conservative management. Patients were excluded if they had any previous surgeries with affected feet or any other pre-existing metatarsophalangeal conditions. Clinical assessment was quantified according to pain and assessed pre- and post-operatively using the visual analog scale. Weight-bearing AP and lateral foot radiographs were obtained pre- and post-operatively, assessing the hallux valgus angle and intermetatarsal angle. Complications were also noted, and patients were asked to rate their satisfaction. All statistical analyses were conducted using Stata 14. Descriptive statistics were analyzed, and paired t-test was used to compare pre- and post-operative outcomes. Now presenting the operative technique, the patients were placed in supine with the operative foot hanging from the table. And the initial incision was made at the medial edge of the proximal phalanx using a beaver blade, and a smooth elevator was used to lift the capsule in dorsal and plantar sweeping motion to create the joint chamber. Exhaustosectomy was initially performed using a 2.0 mm Shannon burr for completing the capsular detachment, followed by a 3.9 mm wedge burr. Excess fragments were removed by applying proximal to distal digital pressure, and the reinforced bone discharger was used to clean the milled surface. The lateral basal osteotomy was performed in the proximal metaphyseal area, and a lateral corticotomy at the base of the osteotomy site, followed by a plantar dorsal corticotomy, was performed using the wedge burr. The 2.0 mm Shannon burr was vertically positioned with a translational motion medially without fracturing the medial cortex. Osteoclasia was performed with one hand stabilizing the midfoot and the other hand performing a gentle closing of the osteotomy. Lateral release was performed with an abductor tenotomy using the beaver blade. Aginosteotomy is performed through the same incision on the medial edge using the Shannon burr. Extensive irrigation is done, incisions closed, and two sterile gauze pads applied with the forefoot wrapped in a Velcro type bandage from lateral to medial and dorsal to plantar, allowing pressure on the first metatarsal head to stabilize the osteotomy and metatarsus varus. A gauze folded lengthwise is wrapped around the hallux like a scarf, and tape is applied on the lateral side of the hallux to close the phalangeal osteotomy and then the medial side in order to reduce varus malalignment. Final imaging was done to verify reduction. A semi-rigid shell was placed on the plantar arch of the foot in order to elevate the first metatarsal and to avoid a secondary displacement of the basal osteotomy. And prevention of lateral translation is done by taping the hallux with the second toe. Patients were asked to follow up after 15 days, during which the first dressing change and reapplication of new bandage was done. On the 30th postoperative day, the bandage is permanently removed. Here are the results. 162 feet and 114 patients were included. The VAS score had a significant improvement from 6.2 to 1. And at the latest follow-up, 97.3% were satisfied and 96.4% of patients would recommend the surgery. The pre- and post-operative radiographic parameters were statistically significant. And a total of 29% of complications were noted. The most common complication was transfer metatarsalgia to the second metatarsal, followed by complex regional pain syndrome and delayed union, and then elevatus of the first metatarsal. Our technique differs from previously published studies wherein internal fixation isn't necessary. Our technique allowed good correction of moderate to severe deformities comparable to a similar technique which uses internal fixation. We also had good outcomes for most of our patients in the short term with improved pain and mostly satisfied patients. Transfer of metatarsalgia is a common complication related to shortening of the first metatarsal, and in our study, this was the most common, which we attributed to an undocumented shortening of the first metatarsal. And our technique can be used for deformities of any severity but has a steep learning curve and requires the use of an image intensifier. It should be emphasized that surgical technique alone cannot substitute the added stability of internal fixation. The bandaging technique for the postoperative dressing is essentially as important as the surgery. Therefore, incorrect application of the postoperative dressing could lead to complications. Limitations of our study is the retrospective nature and the lack of validated outcome instruments. We also did not evaluate radiographic shortening of the first metatarsal. And lastly, the follow-up period in this series was insufficient to evaluate long-term outcomes and recurrence. Finally, we conclude that percutaneous implantless basal closing wedge osteotomy is a reliable and effective procedure with acceptable outcomes as patients were still generally satisfied with the procedure despite complications. We encourage the use of this technique with emphasis, however, that the surgeon should be proficient in performing this procedure and should be able to recognize when internal fixation may be needed in order to limit the complications shown in this study. Here are my references. Thank you for listening, everyone, and have a blessed day.